Scaphoid fractures. Epidemiology. Scaphoid is the most frequently fractured carpal bone, most common in young adults. Anatomy. Parts of the scaphoid: proximal pole, distal pole, waist, tubercle. Articulations. 75% of the scaphoid is covered by articular cartilage. Articulates with the radius, lunate, capitate, trapezium, and trapezoid. Blood supply. Dorsal branches, from radial artery, 80%, through dorsal ridge. Volar branches, from superficial palmar arch, 20%, through the tubercle. Distal branches, variable. Biomechanics. Scaphoid flexes with wrist flexion and radial deviation. Extends with wrist extension and ulnar deviation. Mechanism of injury. Axial loading on a hyperextended, radially deviated wrist. Associated with scaphoid non-union advanced collapse, SNAC. Classification. 1. Site. Waist, 65%, high risk of non-union. Tubercle, 20%. Distal pole, 10%, good healing. Proximal pole, 5%, slow healing. 2. Fracture pattern, Roos classification. Horizontally oblique, transverse, vertically oblique. And 3. Stability, Herbert classification. A. Stable fractures, e.g., tubercle, incomplete waist. B. Unstable fractures, e.g., displaced waist, proximal pole, trans-scaphoid paralunate dislocation. C. Delayed union, less than 6 months. D. Non-union, greater than 6 months. Clinical features. History of trauma. Pain localized to the anatomical snuffbox and scaphoid tubercle. Weak grip strength. Provocative tests. Watson test. Scaphoid compression test. Investigations. 1. X-rays. Views. AP, lateral, scaphoid view, AP with 30 degrees ulnar deviation, and 45 degrees pronation view. Assessment. Fracture site and pattern. Humpback deformity. Exclude carpal instability. 2. CT scan. For confirming diagnosis, evaluating collapse, sclerosis. 3. MRI. Most sensitive for occult fractures, less than 24 hours. Detects ligamentous injury and avascular necrosis, AVN, of the proximal pole. And 4. Bone scan. Detects fractures within 72 hours. Scaphoid. Published by WordPress.com. Management. 1. Conservative treatment. Indications. Stable fractures, distal pole, tubercle, or incomplete waist fractures. Methods. Thumb spica cast. Long cast. Recommended for the first 6 weeks. Duration depends on fracture location. Tubercle. Approximately 6 weeks. Distal third. Approximately 2 to 3 months. Middle third. Approximately 4 months. Proximal third. Approximately 5 months. 2. Operative treatment. Indications. Translation, angulation, rotation, deformation. Displacement greater than 1 mm. Intrascaphoid angle greater than 35 degrees. Radiolunate angle greater than 15 degrees. Scapholunate angle greater than 60 degrees. Humpback deformity greater than 15 degrees. Associated trans-scaphoid paralunate dislocation. Methods. Percutaneous fixation. Herbert or cannulated compression screws. Open reduction internal fixation, ORIF, volar approach for reduction and dorsal fixation. K-wires or screws, volar, dorsal approach. Radial styloidectomy in cases of impaction osteoarthritis. Arthroscopic assisted fixation, Geisler technique. Direct visualization for reduction. Allows management of associated soft tissue injuries. Surgical approaches. 1. Volar approach. Ideal for distal pole, waist, and humpback deformities. Interval. Between FCR and radial artery. Advantage. Full exposure of the scaphoid. 2. Dorsal approach. Preferred for proximal pole fractures. Interval. Between EPL and extensor digitorum tendons. Advantage: preserves vascularity. Complications: non-union. Risk increases with proximal pole fractures. Malunion. Humpback deformity. Avascular necrosis, AVN, particularly of the proximal pole. SNAC. Progressive collapse secondary to chronic non-union. DISI. Dorsal intercalated segment instability.